on the website, so it will be accessible to others. So I'm Dr. Tremontano. I'm the medical director here at the Neurocognitive Institute. And for those who are on the call who may not be that familiar with the Institute, we specialize in cognitive neurology. So we assess and treat mostly patients with cognitive disorders from different types of conditions. In the younger population, some of the common disorders that we evaluate and treat include like attention deficit disorder and autism and various learning disabilities. The kind of adult population, some of the common, more frequent conditions that come in for the services we offer are things like a stroke and traumatic brain injury and multiple sclerosis, those kinds of conditions. And then in the older geriatric patient, a lot of the neurodegenerative diseases. But today, we're going to focus in on what's called mild cognitive impairment. That's what MCI stands for. And most of the mild cognitive impairment that we're going to be focused on, the cause is going to be from Alzheimer's disease. So lots of different diseases and conditions can cause mild cognitive impairment. All of those conditions that I mentioned earlier, like multiple sclerosis and Parkinson's disease and concussion, they can all cause mild cognitive impairment as well. But today we're going to focus on the type of mild cognitive impairment that is caused by Alzheimer's disease. Alzheimer's disease is a fairly common neurodegenerative disease, so that means it's progressive. It gets worse over time, and when it goes on for a long time, it can cause a dementia. That is when the patient's probably not able to function by themselves any longer. So we're not going to talk about that stage of the disease. We're going to talk about the earlier stages of the disease, when it starts to first become symptomatic, when patients start to show what we call cognitive deficits. They get changes in their memory and in their language and ability to do things. We're going to focus on that stage, which is called mild cognitive impairment. Now, that doesn't mean that the disease begins around that time. We'll talk about that. The disease begins way ahead of that time. So in some cases, 10, 15 years, even prior to the mild cognitive impairment phase. So the earlier that we can get to the disease, the more successful we might be in treating it. So to do that, we need better tools to diagnose the disease, in this case, Alzheimer's disease, and we need better tools to treat it. And so today, we're going to talk about some of the newer tools that we have in diagnostics, called functional brain mapping, and some of the treatments that are being investigated for mild cognitive impairment in Alzheimer's disease and treating a number of different disorders called neuromodulation. And we're going to focus, excuse me, later on about non-invasive. So these are types of treatments that we're going to talk about that don't require any surgical intervention. Okay. And then we're going to take some questions at the end too. So if you have questions, you can just write them down, jot them down, and we'll take some questions in about 20 minutes, 30 minutes or so. All right. So let's talk a little bit about the diagnostic process. How do you diagnose if a patient has a cognitive disorder such as mild cognitive impairment, and then how do you diagnose what's the cause of that cognitive disorder? Because like I said at the beginning, lots of different conditions, injuries, diseases can cause cognitive impairment. It's very easy to disrupt our capacity to, attend and concentrate and retrieve information and get things done. So we're going to talk a little bit, how do we know what the cause is of these disorders? So it starts with what's called a functional exam. So in the functional exam, there's a lot that goes on in this exam. You do a neurological exam, a psychiatric exam, and then there's a lot of cognitive testing. So cognition can be broken down into different categories. So we assess, things like wakefulness, can the patient sustain alertness, attention, language, the ability to process information, how quickly or how slowly it's taking them to process information. Domains like work and memory. Work and memory is like if you go into one room to get something, you kind of blank on what you walked into that room for. Was that working memory that holds why you went into that room to get something. It's working memory when you're trying to type an email or write, that holds your thoughts for a second or two so that you can rearrange them and organize them before you type a response or before you speak. So all of these are part of the functional assessment. So that's one of the first things you have to do. It's impossible to make a diagnosis, almost impossible to make a diagnosis of cognitive impairment or cognitive disorder unless you give cognitive testing. So just 15 years ago, not that long ago, very few patients even got cognitive testing. So it just shows you how far we've come in the last couple of decades. Now it's much more common. I know it sounds a little strange that you get a diagnosis of a cognitive disorder without getting tested, but that was definitely more common than it is today. So you have to go through these types of tests. Just like if you get diagnosed with high cholesterol, you have to have a tool to diagnose that. In that case, it's usually a blood test. Or if you get diagnosed with high blood pressure, you need a tool to diagnose that. That's the blood pressure cuff. So in this case, these are cognitive tests to make the diagnosis of a cognitive impairment, and then what type of cognitive impairment, okay? And then this is an example just of the different diseases. For example, this is just in neurodegenerative diseases, like Alzheimer's disease, vascular disease, neurovascular disease, frontal lobe dementia, Lewy body. These are very common diseases in geriatric patients that can cause cognitive impairment. But if you notice, it causes different profiles, right? You see the different bars. And that's the next thing that we do to try to understand, if a patient has mostly memory problems, like what this big long yellow bar is, and they having some visual spatial problems, and maybe language problems, such as naming objects or remembering people's names. That creates a particular profile that you see in certain diseases, but not other diseases. So once we know what type of cognitive problem a patient has, and then we do a profile analysis like this, it gives us an idea of what kind of disease or disorder might have caused that. And that's very helpful to get the process started in looking at what we call etiology, looking at what's the underlying cause or causes of their cognitive impairment, because you want to treat not only at the level of the cognitive impairment, like you want to treat the memory problems, the language problems, the visual spatial problems, but you also want to get at the disease, and if you can, treat at that level, whether it's Alzheimer's disease. And of course, those drugs and treatments are still in clinical trials, which we do a lot of here, but you can get patients into clinical trials and get exposed to what we call disease-modifying therapies. So you're really treating at both levels, the cognitive level, and once you understand what the disease is, the disease level. So you don't want to treat somebody for Alzheimer's disease if neurovascular disease is what's causing their cognitive impairment. And that happens very commonly. Very commonly, people are treated for a disease such as Alzheimer's disease, because a lot of people, including practitioners, know about that, but yet the patient may have some of these other diseases, not Alzheimer's disease, and they're being treated for Alzheimer's disease when in fact they don't have Alzheimer's disease. That was one of the biggest reasons why so many trials have failed, clinical research trials, over the last several decades, because there was a lot of patients in those trials that didn't have Alzheimer's disease. So we've gotten better at diagnostics to make sure that, patients are in a particular treatment and we know what disease they have. So just to recap, to go back, so we talked a little bit, you're going to first do a functional exam, which includes all of this stuff and testing. And then we usually do what's called a structural image, where you're doing like an MRI, where you're looking at the tissue, and that gives us some information as well. So that's another important part of the workup. That's we can also do some measurements of these different areas with software. And functional brain mapping, which is what this is showing. And you can see, in this case, posterior cortical pathology in the back part of the brain. So when you do, this is the software that we use to analyze that. So when you get to do all three of these, functional exams and cognitive testing, structural images, functional brain mapping using tools like fMRI, functional MRI, electrical neuroimaging, you can get at what the pathology might be. Like, does it seem like it's caused by an amyloid pathology and you'd want to look at anti-amyloid treatment? Or does it look like it's one of the diseases caused by what we call tauopathies or synucleinopathies, like in Parkinson's disease? So you want to ultimately get to this point and try to understand the cause of the cognitive impairment, okay? So then once we do all that, and this talk is about treating mild cognitive impairment from Alzheimer's disease, and we have a patient that has Alzheimer's disease, and some of the specifics for diagnosing Alzheimer's disease, then they go into that particular treatment, not only for treating the cognitive problems of Alzheimer's disease, but also trying to get at the disease itself. And this is a picture of a schematic of a brain slice. This is where the disease usually starts for patients in what's called the entorhinal cortex, and it spreads throughout the hippocampus. And you can see it here in this blue swirl of pathology. It starts. And keep in mind, when patients are coming in and we diagnose them with mild cognitive impairment, and we make the assumption that it's from Alzheimer's disease, and they might be in this stage, but this process can start 10 and in some cases 20 years. So if you have a patient who's 75 years old, who's presenting with mild cognitive impairment from Alzheimer's disease, that patient could have started as early as 55 with the disease process. And so by the time they come in, they're already showing pretty good pathology in this area of the brain. Usually it's in this area. And if they come in a little bit later, where they may be even in the later stages of mild cognitive impairment, maybe starting to get into the early stages of the dementia phase of the disease, you can see the pathology really already spreads both posteriorly as well as anteriorly, and then it spreads dorsally up through here. So by the time you have dementia, the patient's brain is ravaged with pathology, unfortunately. So once a patient's in dementia, it's nearly impossible to treat at that stage. Okay. So in Alzheimer's disease, there are certain things that we can do to make the diagnosis. Like once we know there's mild cognitive impairment, there's certain changes on neuroimaging that tend to be very consistent and seen mostly in Alzheimer's disease. So for example, some of these images I showed you here, some of the measurements, this is a patient again with posterior cortical atrophy for Alzheimer's disease, tend to be very specific for the disease. So through these more updated tools that we have, like different ways to look at mapping, and these are connectivity maps, we can make a diagnosis of inclusion as well as exclusion to get at the question, what's causing the mild cognitive impairment? So there's different types of PET scans. This is a FDG PET scan. We also have amyloid PET scans. This is connectivity mapping, where you see a lot of loss of connectivity, particularly in the hippocampi in Alzheimer's disease. You see a lot of, this is the time, excessive time that it takes for the brain to communicate across these areas. So once we have the cognitive disorder and we know or think we're pretty confident in knowing that it's from Alzheimer's disease or caused by Alzheimer's disease, we want to start some various treatments for the patient. So when they come into this institute, we have a particular protocol that they follow. So there's a lot of things that we can do to what we call optimize the brain, to try to make the brain as strong or as responsive as we possibly can. In the world of cognitive neuroscience over the last decade or so, we've learned a little bit about that in terms of, boosting up the brain. So there's ways to do that through certain types of diets, certain types of exercise, some neuroprotective agents we use, and we also use a lot of what's called neuromodulation. So let's go talk about neuromodulation and what that all means. So neuromodulation, there's different types. So I just generically broke it down into what we call invasive and non-invasive. So the invasive, some of the typical or more prototypical invasive forms require, for example, what's called deep brain stimulation. This requires a neurosurgical procedure, which is approved for a few different conditions, like Parkinson's disease, for example. But this is considered invasive. We're not going to be talking about that today. ECT, it's electrical convulsive therapy, we consider that invasive, even though it's not a surgical. You have to create a very generalized seizure throughout the brain. It requires anesthesia and using other benzodiazepine medications so that you can quell any of the physical convulsions. So we consider that invasive. We're not going to talk about that one today either. And then there's many implanted stimulators, vagus nerves, spinal cord that can help with various things. And again, those are invasive. The good news is the non-invasive techniques, even though there's still most of them in the research world, they're getting better and better and can get and do things that these more invasive procedures do, which is very exciting because, as you'll see from the presentation, these are really pretty easy to administer, that it's fairly painless, easy for the patient to tolerate, don't require any anesthesia, no really significant side effects. So this is a really promising and exciting area of research in the non-invasive. So let's talk a little bit about these non-invasive neuromodulation techniques, and then we'll talk about the protocol that we're doing right now with our Alzheimer's disease patients who are in the mild cognitive impairment phase of the disease. So this is transcranial magnetic stimulation. So we're not going to really talk about this one today. We don't do this one. Requires magnetic coils. The R is just repetitive. But this is approved for treatment refractory depression is one of the approvals. So we're not going to really spend too much time about that. We're going to talk more about these guys. What's called transcranial, that means through the skull, a direct current, and alternate current, that's what the AC stands for. So tDCS is direct current stimulation, tACS is alternate current stimulation, and then tRNS is random noise stimulation, just a bunch of different high frequencies that are administered. So these are the three that we're going to talk a little bit about. The most studied for cognitive disorders by far is tDCS. There's been close to 1,000 studies, not all in cognition, but many of them in cognition. So tDCS, tACS, and tRNS, they can be used typically for 4 different indications. So cognitive disorders, which we're mainly talking about today, pain, they have a role in managing pain, epilepsy, which is seizure disorders, and a variety of neuropsychiatric disorders like depression, anxiety, schizophrenia, obsessive compulsive disorder, etc. So those are the 4 indications that these non-invasive techniques are typically used for. So again, cognitive disorders, pain disorders, neuropsychiatric disorders, and epilepsy. So we think that there are no central nervous system indications for tDCS yet. We think there's a pretty big international study going on in epilepsy. Like I said, there's been close to 1,000 studies across these different categories. But we think that in a couple of years, if that gets approved for treatment for seizures, then you'll have a central nervous system indication for tDCS, and then you can use it for off-label for other related treatments as they hopefully will get approved down the line. tACS has it's a little bit different category. It has a FDA clearance for mood disorders like anxiety, depression, and insomnia. And tRNS has no indications yet, but shows a lot of promise in cognitive disorders. Okay, so I'm going to go show you what these neuromodulation look like. We're going to use these slides here, and let me jump to okay. So conventional tDCS, you use these large pads, and most of your studies have, because this is when it first came out, have used conventional tDCS, you know, typically over the dorsal portion of the cortex here to try to enhance cognition, and there's been a lot of studies to support that hypothesis. The thing about that is it causes pretty large change in electrical field, and you don't always want to do that. You don't always want to, in this case, you know, activate large areas because, sometimes that's very akin to, for example, what medication does. So, like if you give an ADD kid, for example, a stimulant medicine, well, there may be only certain parts of the cortex that needs to be stimulated from a stimulant medication. So maybe these frontal structures here need to be stimulated because these are your, big hub here for attention, big hub here for inhibitory control. So when you give a medication, for example, you only want to hit maybe those hubs, just those areas. You don't want to hit everything else because you might have a ton of hyperactivity in other areas of the brain. So where some areas are sluggish, there's going to be other areas that are hyperactivated. And that's very, very common in every condition. The brain is like, in some ways, you can think like a seesaw. So in some areas that are up, there's going to be areas that are down and vice versa. So with medication, you don't have the luxury always of a guided missile going just to the couple hubs that you want to stimulate. Well, same thing in conventional tDCS. If you're trying to activate some hubs that are not activated any longer in a particular region of the cortex, you don't want to overactivate the areas that may be compensating for that underactivation. So that's where, this is an example of the large electrical field going all over the place in these green arrows. So that's where, high definition tDCS comes in. And the Alzheimer's disease protocol that we have right now that's going on in mild cognitive impairment uses high definition. And if we want to get to a certain area, even deeper in the cell side here, deeper in the gyri here, or you want to even go, even deeper into the brain, like when we try to hit like some of the memory centers that are deeper in the brain, you can get there with the high definition, and you can stay, as you can see here, pretty focal and get pretty deep into the brain to hit structures that we would never have been able to hit with conventional tDCS. And it's perfectly painless and doesn't cause any damage. After 1,000 studies, there's no damage and no serious side effects. So it seems to be very, very safe, and yet you can be pretty focal and get pretty deep when you need to. So this really opens up a lot of opportunities for a whole bunch of different conditions when you want to be, very specific in either turning something up or turning something down. Like we talked about seizures, and that's a case where you want to turn things down in a certain area where the seizure is starting from. Well, in things like Alzheimer's disease, you want to turn things up, particularly like the memory center. Okay? That's the advantage of the high definition tDCS. And this is kind of what it looks like. These little EEG sensors, usually put a cap on the patient's head. Sensor is pretty small, so EEG sensor. And if we're trying to activate an area somewhere over here, this is a very common 4x1 design. And we do that. And then there's ways to measure if we've activated the area we wanted activated, or turn down or turn off the area we want to turn off, like in obsessive compulsive disorder or anxiety, etc. So this is just pictures of the equipment and the mapping. So again, this gives you an example. If we're treating up here, you can stay pretty focal. If you're treating over here, you can stay pretty focal in the area where you want to treat. So in our Alzheimer's disease study, we have two models. So we're studying two different, we're studying a number of different things, but we're mainly looking at two different types of treatment. One that we call a resuscitation model. That's where we're trying to get. Let me go back to hold on. Let me go back to those other slides. So let me just flip back here for a second. So if the patient's pathology is, say, right here, where you see this kind of deep orangey red spot, which is, you know, measured with the functional testing we talked about, like this type of stuff. So we can see the problems that result from that on the testing. So we can also test if the treatment's working. So if you want to just get to this particular area, we call this the resuscitation model, meaning we're trying to so-called resuscitate this area of the brain, make it more responsive again, so that it can do what it's intended to do. In this case, a lot of visual spatial, you know, being able to drive or do mathematics, or count, et cetera, et cetera. So that's the resuscitation model. So if a patient is qualified for the study, they have to have mild cognitive impairment. They cannot be in the dementia phase. They have to have, in this particular study anyway, Alzheimer's disease. And once we determine all that, and we see where the pathology is on all the different diagnostic testing, we would do 3 rounds of treatment to try to resuscitate this area. So, for example, let me show you something. So if you look at the studies that have been done so far, here's an example of a table of some of the studies that have been done in Alzheimer's disease with things like tDCS, for example. If you notice that these are just all short-term studies, and they, for the most part, in mild cognitive impairment, not dementia phase, it's too late, but they got improvement on things like executive functions, overall cognitive score, things like naming and word recognition, et cetera, et cetera. So that's very promising, very exciting. But these were just all short-term studies. We don't have long-term studies, and that's why we're looking at this particular study, to say if you keep activating this, so for example, if we're successful in activating this area, which we can easily do, then we have to see if it translates into improved functioning. When you do that, patient might come in, you know, maybe 8, 9, 10 times in a couple of weeks. Treatments may take about 20 minutes, 30 minutes. We make sure we hit that area, it's activated. There's different ways to do that and look at that. And then we retest them and see if we got functional, did we achieve functional improvement? And then they get a couple week break. They come back in a couple weeks, and we do it again. Maybe another 4 or 5 treatments is how the protocol is written. And then they get a longer break, like 3 or 4 weeks. They come back again for another few treatments. And then ultimately what we're trying to do is say, how can we keep that area going? Like, do they need to come in, you know, once a month, once every 45 days, so that we can keep that area, what we call resuscitated, so that it doesn't die off and get worse. We keep it active is what we're studying. So we do that in this particular study. So patient might come in for 18 treatments over the course of a couple months. And then what happens in this particular study is they get what we call washed out, meaning that 5, 6 weeks we let whatever results we might have achieved because if you don't keep doing the treatment, like once every couple months or whatever, the gains will disappear. So in this study, we do that. We let to the baseline, so to speak, and then we do another treatment. But this time, we're not going to treat in the area that's damaged. We look for there's ways to do that with the technology you learned about today, and we go in that area, which is healthy, that's actually compensating for this area, and we do a similar treatment, 3 rounds of treatment, and again we get the results. And then what we're doing is we're comparing the so-called compensatory treatment with the resuscitatory treatment. And then ultimately we pick which one's better or combine the two. And then the patient stays on that for a couple years, whichever the best one is, or the best combination in some cases, so that whatever their maintenance is over the course of the next 2 years, they're going to get exposed to that best fit treatment for them. And in the beginning, we will enhance cognition, and we'll be able to maintain that enhancement over the course of 2 years so that the patient doesn't decline. Because as we said from the beginning of the lecture, Alzheimer's disease is a progressive condition. So it gets worse and worse, as you saw from the slides earlier. The disease ends up ravaging, pretty much the whole entire brain. So that's what the nature of the treatment is, and how we do it, and what we're looking to do. And it's right now we're doing that in the clinic, and we're collecting some data at the Neurocognitive Institute, and we have a couple of grant applications to try to get the study funded. Patients want to participate. They come in and we evaluate them and see if they're fit. There's other studies that are going on with this technology as well. It's not just in Alzheimer's disease, but today's talk is on that. We will be having some other seminars down the line with this type of approach using brain mapping and neuromodulation in treating other disorders. But right now we're just focusing on Alzheimer's disease for this presentation. So I'm going to pause it here and take some questions from the audience if there's any. So go right ahead if you have any questions on anything that we spoke about today.
Yes, I have 2 questions. Can you hear me?
Yes, I can.
Okay. The first is, what is the actual mechanism of action that will cause the cognitive impairment to improve when you do this stimulation?
Yeah, it's a good question. So there's probably several mechanisms of action. So there's oscillatory activity. So from a neurophysiological perspective, what we typically see, and depends what you're doing, what type of neuromodulation, but you could take an area. So for example, let's go back to this picture. Well, we can use this picture. So if we have 2 hubs across the hippocampi, left hippocampi, right hippocampi, and you stimulate them simultaneously, you get reconnection, you get functional connection. These blue streaks kind of go away. So one potential mechanism of action is functional connectivity. Cells that fire together kind of work together. So in our model, some of our patients not only go through tDCS, they also go through tRNS and tACS. We're looking at all 3. So you get potential change by changing connectivity.
I see.
That's one potential mechanism of action. Other things that occur is you get change in oscillatory activity. So for example, let's go find, okay, this I believe is probably at about 4 hertz. So this is a very, in the cortex, that's very problematic, because when you're listening right now to me talk about this stuff, you're processing probably at 40, 60 hertz to process that information. And the more your brain's working, the more it's processing. So when you're at rest, this is a picture at rest, at 4 hertz, that's a long way off. So if you can activate that, and a lot of times we see that, go away. And I didn't mention about neurofeedback. That's another form of neuromodulation. But anyway, next seminar. So we see changes in the tone, so to speak, the cortical tone. So that's another potential mechanism of action. And then there's been quite a few studies on those slides that I skipped over, showing neurophysiological changes in glutamate activity and serotonergic activity and many other neurotransmitters. So like many things, we don't know exactly the mechanism of action for the enhancement, but there are neurophysiological and neurochemical changes that are probably responsible for the improvement in cognition.
Okay. And my second question quickly, if your protocol does enhance cognition, does that have any effect on the underlying Alzheimer's disease, such as slowing its progression or ceasing it?
Well, that's what the nature of this study is. So, for example, if we go back to here, these are all Alzheimer's disease studies, and a lot of these were done with conventional tDCS. So these are big swaths of electrical field, not just hitting the left dorsal prefrontal cortex that's up in the left frontal lobe. But they got, in many of these studies, enhancement, but they were all short term. So nobody has looked at the disease modifying properties or the potential disease modifying properties. So that's why our study is for 2 years. We just don't know. So yeah, you can get some enhancement. Some studies have showed enhancement in the hippocampi, what I call the resuscitation model. Some are getting cognitive enhancement using maybe compensatory mechanisms. So this would be this bilateral temporal parietal, even though this was not high density, this would be consistent with a resuscitation model in Alzheimer's disease. Whereas this dorsolateral prefrontal cortex on the left would be considered what we're calling compensatory. So yes, they do get some gains here, but we don't know what that means for the disease. And that's why we need studies for 2 years, at least 2 years, in order to answer that question.
Okay. While you're talking, another question occurred to me. I don't want to take too much of your time.
Sure, go ahead.
Is this age related, so that a person who is younger, as opposed to a person, let's say a person who's 75, as a person who is opposed to being 85, 90, would this have more of an effect on a younger person rather than an older person, or doesn't it matter?
Yeah, it's a great question. We don't specifically know, but we have some ideas. For example, we know why we failed miserably as Alzheimer's disease researchers over the last 100 years is because we jumped in too late. We tried to treat way too late. So in general, we know not so much age-related, but pathology-related. The later you go, the less likely you're going to get efficacy. So if you have somebody who's, let's go back here. So if you have somebody who is, let me just move this out of my way for a second. So if you have somebody that is 75 years old, let's go, okay. And or let's say this person is 85 years old, but you're catching them with their disease maybe at this stage of the game here, okay? But you catch somebody else who's 70 years old, but their disease is already this progressive. Chances are, this patient who's 85 years old, who has less disease, is going to do better.
Yeah, that's right. I see. Thank you.
Sure.
I get you. I get it. Yeah. So it's really how far the disease has progressed, not necessarily the age itself of the person.
More or less. More or less.
Okay.
Yeah. Yeah.
Okay.
But
Thank
the
you
other
very much.
complication is, absolutely, the other complication for people to keep in mind is as we get older, like for example, if a patient comes in and we diagnose them with mild cognitive impairment and they get the workup and they have Alzheimer's disease as the cause, and they're 68 years old, chances are that's all they have that's contributing to their pathology. Whereas if you get a patient who's 88 years old, chances are that it's not just Alzheimer's disease. Chances are for that patient, there's other what we call comorbidities that are contributing to cognitive impairment. So there's a general rule: the younger you are, the more likely there to be a single etiology. The older you are, the more likely there is to be multiple etiologies causing the cognitive impairment. So again, like anything else, you know, the more diffuse the pathology, the more difficult it is to treat. So in general, that's why we recommend people get, you know, just a screening early in your 50s. It's a good time to get screened and go from there.
That's very interesting. So that a much older person, like you said, in their 80s, may have the Alzheimer's, but could also have some vascular problems too.
Yeah, yeah. And the typical thinking now, and I think this is pretty much proven now, particularly from the neuroimaging initiative and these databases where we now have 80,000 patients, so you can really build a timeline on what's going on. But yeah, protecting those small tips of the arteries that go deep into the brain is probably the best thing you can do to prevent neurodegenerative diseases, because once that door opens up and the blood-brain barrier starts to become permeable, everything can get in at that point. So this hypothesis, which has been around probably since the days of Hume Jackson back in the late 1800s, has gained a lot of support. That if you can protect the neurovascular structures in the brain, you could probably do a really good job, decreasing and preventing a lot of these other neurodegenerative diseases.
Yeah. Okay. Thank you very much. I appreciate it.
Okay. Sure. Any other questions before we close? All right. Well, like we said, we will post this on the Neurocognitive Institute's website. So there's quite a bit of information. So feel free to, download it or play it, however that works. And we'll be having. I think we're going to be coordinating with Christian, who's been instrumental in launching all of this. A few more in some of the, again, more of the common areas of the disorders we treat. I think we have another upcoming one in autism, and probably we'll talk a lot about ADD and learning disabilities in that seminar. And then I think we're going to be having another one, again, in relation to brain mapping and the various forms of neuromodulation in neuropsychiatric conditions like depression and anxiety and some of these other conditions that may not have responded well to other treatments. So thanks for attending, and hopefully you'll be able to attend some of the future seminars. Okay. Okay. Thank you.